Now for the diabetic foot. Diabetes per se is a very specific identity where it includes your diabetic control, diabetic compliance, controlled, not controlled, complications. We are not talking about the history taking skills now, not for the general examination of the diabetic patients, but what we are concerned about is the diabetic foot examination specifically. So in the you will do systemic examination for the diabetic patients who are coming for a follow-up or for a refill, but for the diabetic foot examination specifically, what you are going to do is you first need to for the diabetic foot, you first need to educate the patient about the diabetic foot. Every diabetic patient should know what to look for in the foot. So you will start with the inspection of the foot, the skin color, the dryness. Are there any dryness? Is there any cracks there? Is there any ulcers? Right, good. And are there any patches in the skin? And then you need to look for the web spaces for candidial infections. You look for the web spaces in order to look for any candidial orifices, any candidiasis, any infections and all that. Then you also need to comment on the yes, sensations. No, before going to the sensations, on inspection. So you will have a comment on the web spaces, you have a comment on the skins, you will have a comment on the nails. Is there any deformities or there not, any fungal infections there or not, what is the general hygiene of the foot. So this is about the inspection and the obviously the hair distribution and all that. And then this is about the inspection. About the palpation, you will start with first the temperature, comparing both the foot. Is there any cold or is there any warm? Is it cold or warm or not? Because diabetic neuropathy or diabetic vasculopathy can have these temperature differences. So inspection, checking for the temperature. Then you need to check for pulses. We are doing the palpation. Then you need to check for the pulses. So which pulse is this? Dorsalis pedis, and this is posterior tibialis. Okay, so you need to check and comment on the pulses, and then you are going to assess for joint proprioception. So you will ask the patient, first you need to explain that, okay, so this is up, this is down, and this is neutral. So can you close your eyes? Is it up? Okay. Where is it? Up. Okay. Where is it? Down. Okay. So you ask the patient to close his eyes, explain the procedure, and then you will do this for the joint position to assess the level of joint position. And then you will do the vibration. You if you have a tuning fork, you will hit the tuning fork, and then you can touch it here in the bony space, here in the bony space, or here in the bony space, wherever. And you ask the patient that when you stop vibrating, when you stop when there is no vibration, just let me know. And when the patient says that, okay, I don't hear any vibrations, and then you can compare it with yourself. Are you going to hear it or not? If you are hearing it, that means that the vibration is impaired in the patient foot. Okay, and then this is for the vibration sense. Then there is a thing called monofilament. It's just a simple plastic rod with very thin. It's like the pencil. It's like the pencil pen. We have this pen, and then we have 4 points in the palmar area. We have 8 points in the palmar areas, 2 in the up, 2 in the middle, and then 2 pairs in the lower, and we have 2 pairs in the in between, and 2 pairs here in the dorsum. So 2 pairs in the up of the, if this is the palmar area, you have, this is big toe, you have 2 points here, 2 points in the middle, 2 points in the lower, and then you have 2 points here in the dorsum. So within these 8 areas you will have an idea that okay, this is, and you ask the patient that I am touching on these areas, are you able to feel it, are you able to feel it? You ask the patient to close the eyes, identify that okay, this is how you're going to feel it, and are you feeling now? Yes. Feeling now? Yes. Yes. So you will comment on, okay, for instance there are 8 areas, so out of 8, is all the 8 areas are good, intact? If 6 out of 8 areas, if 2 out of 8 areas, or if 0 out of 8 areas are perceivable by the patient. So you need to comment on the touch sensations. So this is how you're going to assess for the foot examination. The other thing is the diabetic neuropathy. You can have a tongue depressor and then you can break that tongue depressor. When you break the tongue depressor, it will be sharp from one end and blunt from the other end. This is just the clinical way, not the actual way, but anything sharp you can use it. Maybe the pencil is also fine. And then you will assess for the diabetic neuropathies. How are you going to assess for the diabetic neuropathies is that you ask the patient, okay, you feeling like this, right? And you need to compare. So I'm trying to start from the proximal, from distal to proximal, and let me know you're feeling, right? And let me know when you feel more. So when you go up, sometimes the patient at this point he will say that from now onwards I'm feeling more sensation rather than this. So this is how you can differentiate between the glove stocking neuropathies, and then you compare it with the other thing. So you will start from the proximal, from the distal, and going up proximally, and in order to differentiate between the glove stocking neuropathies of the diabetic foot. So that's about the examination of the diabetic foot. Diabetic foot care and education includes explain the patient about your need to examine your foot by yourself. You need to see if there are any ulcers, or if there are any cracks, or if there are any dry patches. You need to carefully look after that. Number one, if you see any abnormality, you need to come back. Number second thing is you ask the patient to use comfortable footwear, and you also need to assess by yourself that the footwears are comfortable or not, size is good or not. If you see any redness or any hardening, this is called callosities. If you notice that there are callosities here on the weight bearing areas, that this is the first sign of developing the foot ulcers. That means somewhere is wrong somewhere. Either he is very prolonged standing, or there is a problem in the footwear. So you need to alarm the patient about this callosity. So the first stage is the callosity, which can denote that there is a problem in the foot. There is going to be problem in the foot, number one. Number second stage would be redness. This is the erythemas. This is just the first stage. And then you will have some erosions, and then you will have involvement of the subcutaneous tissues. Grade 3 you will have involvement of the muscles. Grade 4 you have involvement of the bones also. So this is the foot ulcer grades, right from the callosity to the redness to the subcutaneous tissues to the muscles, and then to the bones, exposing to the bones. This will lead to the osteomyelitis. But here, as a family physician, you need to screen those patients up, educate those patients about the developing of the diabetic foot problems, and take care of their foot by using emollients and by using comfortable footwears within the diabetic foot examination. That's it.
What are the criteria if we want to refer? How we see the ulcer to be just a relief from?
The criteria for referring a foot ulcer, right?
Yes.
Developing a foot ulcer is not a criteria for referral. You can manage the diabetic foot ulcers. If it is obviously red, you surely need to manage it. No problem with that. You just managing it by assessing for the footwears and for the diabetic control. Okay. The second thing is, if you have subcutaneous tissues in there, even then You can manage it with dressings, with the sugar controls, and with the footwears, and then you need to see the progress. Somewhere in between the subcutaneous tissues and muscles, if you think that you're not an expert dressing it in a proper way, then you can seek help, but it depends on the individual person or the nursing facilities or dressing facilities available. So if the patient has grade 3, grade 2 and grade 3, like there is an ulcer which has subcutaneous tissues and muscles in it. So first need to inspect the wound. If the wound is clear or not. You also need to educate the person who has this ulcer or the caregiver that the wound is healthy or not. This is a sign. How are you going to know? How do you going to know? Is you know that if there are sloughs present, like white areas present, so this is not a good wound. You need to peel that slough areas. The wound should be red and shiny. This is a good healthy wound. So this is how you are going to educate the caregiver, or you do it all the desloughing of these things. But it cannot. You can manage it in the primary healthcare if you have the facility, no problem. But for sure, you need to have seek help for this, and this is you will seek help from the general surgeon, not to a diabetic patient, not to an endocrinologist, because this is a surgical problem that needs some deprivement or some good dressing and some good local applications. But that would require a surgical referral. If it is exposed to the bone or near to the bone or very deep, not responding, you are not comfortable, need to refer. So somewhere between 3 to 4 is clear referral. From 2 to 3 you can manage depending on the responses and the facilities that you have. All right, so that's about the diabetic foot examination.